Thanks everyone for being here today. I am Lisi Docanto with the New York State Health Foundation and with the Community Health Network of New York City and our good friends at Columbia. We're going to take a few questions from folks in the audience, if that's okay with our speakers. I see that my colleague from the foundation is here in the back, and I think that she may have our first question. Will you just identify yourself?
Sure, and if I didn't, Lisi would make me come up with that question. Good morning, everyone. My name is Jacqueline Martinez, Senior Program Director at the New York State Health Foundation. Very pleased with the panel this morning and sit here with your remarks. The New York State Health Foundation decided to invest in this initiative because we see that without community health workers, all these new delivery systems are just not going to work. We've been in this place before with Medicaid managed care, trying to really manage the care of what we call difficult to reach populations or difficult to manage populations. But the reality is that people live in complex environments, and community health workers have been known to understand those environments, to connect with people, to build trust with people, and to bring them in and to engage them into a health system. And I know that I'm preaching to the choir, but I just want to reiterate the reason why the New York State Health Foundation, with $300 million of an endowment, understood that without investing in this area, we really weren't going to make much of a dent in the issues that we face today as a nation and as a state. I do have a question, one for Andy and then for our Assemblyman Gottfried. Andy, the question for you, and it's nice to see you again. I actually worked with Andy 10, 15 years ago when you first got that New York Presbyterian program started. You've been in the environment of hospitals now for a while, and my question is, how do we take the program that Presbyterian has proven to work, made it work for the institution? How do we replicate that? How do we take that to scale to other hospitals in New York? And then a related question to that, I know that the world is also shifting with hospitals thinking about their roles in ACOs. What would be the role of community health workers as part of these larger accountable care organizations?
We've been fighting to try to get community health workers integrated into the system.
Can I ask you to go to the mic? Yeah, thank you.
We've been fighting to try to get community health workers into the system for a long time. I think that the environment now with healthcare reform is a good time to bring this to other institutions. We've actually, in order for us to be able to put the program into the hospital operations, we have to do a return on investment that proved that we can save money by using community health workers. And I've shared this with Sally, and I think it's going to also be part of the brochure that's going to be put out. And I think that as New York Presbyterian being such a large institution, I think that it helps to be able to share that with other institutions throughout the state on how you can use community health workers to save money. As I said before, I think it was difficult before because the way reimbursement was given down to hospitals in the past, it related to how much revenue, how many visits you bring in. So the more visits, the more revenue brought in. Now with healthcare reform, it's changed. So I think there's more incentives to get other institutions to join us and continue to work with community health workers, and then really also doing evaluating the program in a real concrete way, so that it's not just that it's a good program, that it's that people like community health workers, but that it actually has some value. In other words, that we've been able to show that it concretely reduces the use of ED utilization. It concretely reduces inpatient admission. So the more we do, I think, these kind of studies to give us some really good, strong outcomes, I think it will help in getting other institutions to buy in. And as far as, it absolutely fits into everything related to these larger networks that are developing. Community health workers, as my view of community health workers, they need to stay in the community. They can, as you know, the program that we have, community health workers are hired by the CBO. We have a contract with the CBO. We pay them for the community health workers, but they're hired by the community-based organization because they understand the community. They are able to train community health workers to, and develop certain skills in the community that we in the hospital would not be able to. to do. So I think that the community health workers play a vital role as we go forward with all these new networks.
That's really helpful. And actually, the return on investment is something that we've kept hearing over and over again, that it's the case that we need to build to really be able to sell this to other institutions.
We had a pretty good case, so
Yeah.
I shared it with Sally.
So Assembly Gottfried, the question for you right now is, your leadership for this whole initiative has been invaluable. With your voice, your support for it has been helpful, not only for the statewide initiative to really stay encouraged and keep moving, but also to maintain the voice at the state level. My question is, what do you need as our state assemblyman to take these recommendations and see them implemented as part of what the state is worried about, which is cutting the cost? The whole idea of the Medicaid redesign team are coming together with these ideas. How does this whole set of recommendations fit, and what will you need from this initiative and the statewide initiative to support your work moving forward?
Good question. But before I tackle that, I just had a thought in response to your previous question about where do you get the money to pay the community health workers. And I was thinking someday I want to hear someone ask, where do hospitals get the millions of dollars to pay the CEO? How do they do that? Where do they get the much tinier amounts to pay the people that mop the floor? Nowhere is there a provision for funding the maintenance workers in a hospital or the CEO. Somehow they get paid. And they get paid because people who run hospitals have figured out long ago that you can't run a hospital without maintenance workers and a CEO and a whole slew of people in between. We are beginning to understand that you really can't run a healthcare system without people doing just about exactly the work that community health workers do. And as people in government and in the healthcare provider world and in the community come to understand that more clearly, and as we hopefully design a healthcare system that makes providers deliver healthcare in a way that requires them to have CHWs on the team and that enables them to provide healthcare in a way that requires having CHWs on the team, then healthcare providers will start having CHWs on the team. And they'll pay those CHWs partly because that cost will begin to be recognized as an essential part and a legitimate part of every healthcare provider's cost reports that are filed with Medicaid. And because healthcare providers will be able to pay community health workers because they will understand that having them on the team brings down the cost of care so that they can live within the reimbursement rates that they're being paid, which may sound like kind of a roundabout thought, but if you look in a lot of the recommendations that the Medicaid redesign team is at this very moment finalizing, on page after page, they almost all talk about care coordination and care management and integration of healthcare delivery and involvement with community resources and et cetera, et cetera. All of that really requires people just like community health workers. And I think what community health workers and people like the New York State Health Foundation and others who have been supporting this effort can do for the legislature and the health department and the governor and other agencies is talk us and walk us through these recommendations and make it clear to us and help us create legally recognized definitions of the scope of what community health workers do and create mechanisms for certification and training and building financing into systems. None of us in the legislature or the executive branch arrived at our jobs knowing those answers. We urgently need all of you to help teach that to us and walk us through making all of this happen.
Thank you. Other questions? Here.
Hello, my name is Anna Parks, and I work for WEACT for Environmental Justice. I am a community health worker. I started being a community health worker 15 years ago, which Sergio trained me. And Ms. Blanca, your story sounds just like mine. I am very happy and proud to be here today after all these years to see that community health workers are being recognized in this manner. We are educators, we are advocates, and we support people. We do assist people for change for behavior. You see, throughout the years, I have many, many stories of families that I have assisted, and to say today that they have changed their lives for their children and for themselves and for the community. And we are a driving force in the community. We know our ins and outs, and we have an understanding and a way to, and it's not an easy process to go into somebody's home and let somebody allow you to sit down and talk to them and be able to make them feel comfortable to do the things that they need to do. But again, I commend you, Sergio. My hat comes off to you. I am so proud to be here today. Thank you.
A question in front.
Yeah, hi. I had a question for, I'm Charu Gupta. I'm with the Community Health Worker Network of New York City as well. And I had a question for you, Glenda, as the community health worker on the panel, is how will, if making these recommendations operational, how will that change your everyday work life? What will that mean for you to go to work every day, knowing that these recommendations are, actually operational?
I work at a hospital-based clinic, and I've been there 18 years. In those 18 years, I have my own office. I work with the clients that come to the clinic, and children under 2 specifically, and getting them in for well child checks, immunizations, which when parents are struggling with hardcore real-life issues and the child's not sick, it's something they don't even consider. So, like I said, I started the program, it was a pilot, and it increased immunization rates. So it became something that the insurance company said, okay, well, we'll give you some grant money, and we tapped into Marquis Jones and other agencies and got some money. And so I currently work under a grant still. It's still grant funded. And because of where I work and because I am a part of the team in my mind, but at the clinic, I'm not. And it's really hard to go in every day when you've been with an agency that long and still be looked at as, you're part of the team, but you're really not, because you could be gone like that, and that's a really hard feeling to go into work every day with, because the work you're doing is just so valuable. Increasing the rates, getting these patients in, educating them. We're going into their home, earning their trust, developing a relationship where they're gonna just eat up all the information we give them. And it's not something so much that's learned, it's just, it's a unique capability, it really is. So, I go in, positive attitude, And I still, to this day, if there's a new worker employed by the hospital, I still get asked, but you're not really, you're not really an employee here. Like, you don't really work with us. And, no, I do, actually, I do. My money could be cut any time now, and I won't have a job because the hospital still, as of yet, has not seen that I work so closely with those providers. And I go out, I let them know anything I see that's kind of, okay, this is why they're not coming in. We need to address this issue. Take care of this. And everything else will kind of fall back into place. And these families will finally trust that there's people out there that will help them, and then that these agencies and the doctors and everything aren't just looking to check them and out the door, So I guess, back to your question, it would change things tremendously for me. I love my job. I love what I do, along with, many other community health workers. But just the feeling of being a real part of a team, and not having to worry so much about your funding, because it makes a big difference, I think that it's well-deserved to be a part of the workforce together.
It's important that we find the right mid-ground between strengthening the profession by having definitions and certifications and training requirements so that people know what a community health worker is, so that they are respected, so that they are included, et cetera. But at the same time, we have to avoid, at least at the early years of this process, making those requirements so rigid that people who are doing the work or who next year will come into the field, but who don't have that kind of training because it was never offered to them, we don't want to lose their services either. So certainly in the formative stages of the profession, we need to guide ourselves on a middle path so that we can both build the profession but include and retain valuable people like yourself.
Schwar had just recently, I think it was June, July, just went through the core competency training. And something that I think is crucial, the competency portion of the training, believe it or not, is going to be more, I don't want to say respected, but more believable to employers and as far as hiring you. I know what you're saying about the training years ago. I went through the same thing. And then there's going to be specific trainings towards your job. But all in all, I believe the core competency training, and it's more of a buy-in, because I know with the people I deal with in Rochester, a lot of it has to do with what kind of training do you have. They don't, they don't quite understand, okay, we specialize in this, HIV, immunizations, whatever, and we know our stuff there. But a CHW, per se, the whole scope of practice type, that's really going to be very helpful.
So from our perspective, we've used core competency training by Sergio in the past, for our community health workers. We are working with one of the community colleges in our area to develop a curriculum for community health workers, and working with Sergio too. So I find it useful to have some kind of training for community health workers, but I agree that the strength of community health workers is the knowledge that they have of their communities, and how they navigate the communities and understand the intricacies of each community. That's the strength of community health workers. But I think that it's important to have some core competencies also.
Okay, I want to thank our panelists for coming here so early this morning. Glenda, I can't even imagine what time you had to get up to get on that plane. Thank you so much for making that effort. It is really so important to us. Andy, I know you're running a huge department in a huge hospital, and thank you so much for taking your time to be with us this morning. And Mr. Assemblyman, I don't know how you do it. I can't even imagine what you're under with Medicaid redesign. I know that everybody that I speak to on that team is berserk right now. And the fact, no, I know. But the fact that you're here this morning and you continue to support us so strongly and is really speaks volumes to the importance of this work and your dedication to our city and our state. And so thank you, Mr. Assemblyman. Thank you all for coming here this morning. We look forward to the rest of the day and the entire conference we've put together today. Have some coffee, we'll have lunch in a little while, and then we'll get going. Thank you very much.